Cardiology Fellow at the Morgan Stanley Children's Hospital of New York, Columbia University Medical Center. He will be speaking about the New York City experience with COVID virus as seen through the lens of the Morgan Stanley Children's Hospital.
If I can interrupt, everybody please mute because somebody's doing the dishes and we can hear it.
Hijo, faltan 3 minutos, amor. 3 minutitos, amor.
Someone
All right, I think we're good to go.
Mike.
Hey, so thank you, Julie, for that introduction. Before I talk about thank you all for having me talk today. Before I talk about the New York City experience, next slide, please. I just wanted to show, this is a map from the CDC showing hotspots across the United States as of the 21st, with a total of 800,000, a little over 800,000 cases. You can see the heaviest hit areas in dark brown with the lightest hit areas in yellow. Next slide, please. And so focusing on New York, indicated by the red circle, you can see why our state is referred to as the epicenter, with more than 250,000 cases as of the 22nd, with neighboring New Jersey experiencing over 92,000 cases as of that day, making up over 40% of the cases across the country. Next slide, please. Here at Morgan Stanley Children's Hospital, we've seen a broad range of cases, both pediatric and adult, and I'd like to share some of the data that we've gathered on our pediatric patients today. Next slide, please. The following data that I'm going to be talking about reflects patients ages 0 to 21 years old with confirmed COVID-19 infection that were admitted as of our data collection period from the end of March to late April. 0 of the 23 patients that we found that meet those criteria had congenital heart disease. 3 of those patients had pre-existing cardiomyopathy or heart failure, and 1 of those patients had received a transplant. In terms of their outcomes, 5 patients were intubated, 1 ended up on VA ECMO, we've had no deaths, and 7 have been able to be discharged from the hospital. Next slide. I'd like to discuss a little bit about our EKG and our echo findings. One of the challenges we faced, although we're not getting as many studies as our adult colleagues, one of the challenges that we've tried to address is balancing the need for clinical information with preservation of personal protective equipment and protection of our team members, specifically our sonographers, with regard to minimizing exposure to COVID-19. In terms of our EKGs, out of those 23 patients that I mentioned, 14 received electrocardiograms, 8 of which were abnormal. 1, we discovered previously undiagnosed Brugada pattern that was elicited by fever. 2 had ST elevations. 3 had new T-wave inversions. And 4 had QTC prolongation. And of note, 3 of those 4 patients were on hydroxychloroquine. In terms of our echocardiogram data, 4 out of those 23 patients received echocardiograms. 2 of those were abnormal, and both of those patients with abnormal echocardiograms had previously known cardiomyopathy or heart failure. Both of them had decreased systolic function, changed from baseline, and 1 of those had mitral regurgitation above baseline. Next. Before I talk about the rest of our pediatric data, because such a significant portion of our congenital heart disease population is made up of neonates, I'd like to shift for a minute to discuss the experience of our obstetrics colleagues with their peripartum population. Early in the course of our COVID response, our OB colleagues discovered several cases of women who initially presented with symptoms thought to be due to typical labor, but not known at the time to be associated with COVID-19 infection. During the course of or shortly after delivery, those women quickly developed severe COVID symptoms and subsequently tested positive for SARS-CoV-2, but only after several members of the care team were exposed. These cases prompted implementation of a universal screening policy for all women admitted to labor and delivery. Our obstetrics colleagues published those cases and then followed it up with this correspondence in the New England Journal of Medicine showing their results after universal screening. Out of 214 women in labor who were tested for SARS-CoV-2 infection, 33 of those women, or 15%, were positive, and shockingly, 88% of them, or 29 of those 33, were asymptomatic, showing that you won't know necessarily until it's too late and many team members have been exposed who's infected and who is not. They end their correspondence by making an argument for universal screening in the labor and delivery population, but also in the inpatient population as a whole. Next. With that obstetrics data in mind, we've been following our neonates with congenital heart disease born to SARS-CoV-2 positive mothers. We've identified 6 neonates so far who are admitted as of the time of our data collection. These diagnoses are listed on the left. You can see all with significant congenital heart disease. Thankfully, all 6 have been negative for SARS-CoV-2 when tested and remain negative. 4 of them were born at our institution, and 2 were diagnosed at other institutions and then transferred to us. All neonates were able to go forward with their required procedures if they were needed, and you can see the day of life that those procedures occurred indicated in parentheses, and 2 of these babies were actually able to be discharged, and all are doing well. Next. As we've learned more, we've also discovered more unanswered questions. Over the last few weeks, to address these, we formed a group within our division to assess our role as acute care consultants and how best to approach the cardiac workup and monitoring of these patients. This group is made up of pediatric cardiology attendings and fellows, some of whom have been redeployed to adult COVID units. Next. We started by identifying major categories for potential consults and grouped them into the following groups. 1, rhythm and EKG questions, for example, sinus tachycardia or other arrhythmias. Medication-related questions, for example, QTC monitoring in patients on hydroxychloroquine with or without azithromycin. And questions regarding the safety of ACE inhibitors or angiotensin receptor blockers in the COVID-infected population. Finally, questions regarding appropriate cardiac testing and monitoring, specifically with regards to interpretation and monitoring high-sensitivity troponin and N-terminal proBNPs, and when to get echoes and EKGs and how to interpret them when we do get those studies. Next. Though we're still learning new things every day, and the natural history of this disease and best practice may change from one week to the next, this table reflects our current recommendations for the workup and monitoring of pediatric patients with COVID-19 infection admitted to the hospital, while minimizing provider exposure and preserving PPE. For COVID-19 positive children in the emergency room without suspicion for cardiac disease, namely normal lab workup, including troponin and NT-proBNP, no cardiomegaly on chest x-ray if one was obtained, and no clinical symptoms such as chest pain, shortness of breath, or edema, or other signs suggesting heart failure. We recommend getting a baseline set of labs as per our hospital's infectious disease protocol, which should include a high sensitivity troponin and should also include an N-terminal proBNP if not already obtained. We do not recommend routine electrocardiograms or echocardiograms in this population. For those COVID-19 positive children in the emergency room with suspicion for cardiac disease, as just defined, in addition to the baseline labs that I just mentioned, we do recommend getting a 15-lead EKG to assess for myocarditis or other rhythm disturbance, or possibly to get a baseline QTC, telemetry monitoring to assess the arrhythmia burden, and echocardiogram to be determined at the discretion of the consultant cardiology team. If it's determined that an echocardiogram is needed, we strongly recommend limiting that study to an LV and RV function check and a pericardial effusion check only, with additional views to be obtained at the discretion of the cardiology team only if there's high suspicion for structural or congenital heart disease. If the decision is made to admit those patients, or if the patient is already admitted, we recommend getting the following additional labs to help with risk stratification. In addition to your troponin and your N-terminal proBNP, we recommend inflammatory markers such as ESR and CRP, ferritin, procalcitonin, D-dimer, and a lactate dehydrogenase, as those in the adult population have been indicated as being associated with increased morbidity and mortality. We do recommend getting EKGs in these patients if the plan is to start a potentially QTC prolonged medication such as hydroxychloroquine or azithromycin. For those children admitted to the intensive care unit, we do recommend routine EKGs for all, a baseline chest x-ray to look for cardiomegaly or overcirculation. We recommend trending high sensitivity troponins Q72 hours and N-terminal proBNPs every 72 hours, in addition to checking the lactate dehydrogenase. Next. In terms of monitoring the QTC for patients starting or on hydroxychloroquine or azithromycin, we've adapted this algorithm from our adult cardiology colleagues to decide when it's safe to start or when it's required to stop this medication, looking at QRS duration and QTC interval to decide for each patient. Obviously, we've needed to modify these somewhat for pediatric population, but it's proved quite useful. Next. Finally, we came up with this list of when pediatric cardiology should be consulted in the pediatric intensive care unit. Specifically, there's significant elevation in high sensitivity troponin, abnormal EKG or telemetry findings, including arrhythmias, abnormal echocardiograms, pericarditis or myocarditis, heart failure, cardiogenic shock or pulmonary hypertension, or pericardial effusion. Next. Putting all that together, our group has assembled teams to address questions that have come up. We have several projects already underway and many that are in development stages, but we've put out several papers already from our groups, specifically with regards to interventional cardiology. Dr. Crystal and Dr. Torres working with interventionalists across the country to put up guidelines recommending how to decide which cases should proceed as scheduled and which can be postponed. Cardiac surgery, Dr. Basha, along with several other cardiothoracic surgeons across the country, putting out guidelines and experiences with regards to congenital heart surgeries, and our pulmonary hypertension group led by Dr. Berman Rosenzweig with regards to how this infection has affected the pulmonary hypertension population. Next. Thank you for giving me the time to talk today, and I look forward to your questions at the end.